Hey everyone, welcome back to Nurse Crit. My name is Chasen. I'm an acute care nurse practitioner. Today, I'm going to talk about one of the most dreaded conditions to show up to the hospital, aortic dissections. These patients are ticking time bombs. If their aorta ruptures, it is game over. Obviously, you want to get these patients to a facility that can treat them, but we have to do our best to stabilize them in the meantime. If these patients make you a little nervous, then stick around and I will teach you what you need to know to properly care for them. By the end of this video, you should be able to understand the pathophysiology of aortic dissections, identify risk factors, signs, and symptoms, recall the most important diagnostic test for dissections, implement early medical management, and provide ongoing nursing assessments. So, what is an aortic dissection? The aorta is the largest blood vessel of the body. It's a tubular structure that comes off of the heart from the left ventricle, goes up toward the head, and then curves back down like a candy cane. There are many different arteries that branch off from the aorta to provide arterial blood to the entire body. The aorta is comprised of 3 layers of connective tissue: the tunica intima, media, and adventitia. When the structure of the aorta weakens, it can result in an aortic aneurysm or an aortic dissection. An aneurysm is a bulge that forms, and while certainly not good, it's not as immediately dangerous as a dissection unless the aneurysm is huge. A dissection is where a tear forms within the inner layer and starts to rip apart the intima from the media layer. Over time, this dissection or tearing can propagate up or down the aorta and even along any of the branched vessels, causing serious blood flow problems to various organs. If the dissection becomes severe enough, it can tear through all 3 layers of the aorta, leading to a rupture. Once the aorta ruptures, most patients will exsanguinate and die within minutes. When classifying aortic dissections, the Stanford Classification is the easiest to remember. A type A dissection involves the ascending aorta, and type B involves the descending aorta. Type A dissections are surgical emergencies and need to be taken to the OR immediately for repair. Type B dissections, unless ruptured, are not considered an emergency and can be managed medically. If they do require surgery, oftentimes it can be treated with an endovascular stent graft, which is cool because that does not involve slicing up the patient for an open repair. Aortic aneurysms and dissections result from weakened aortic tissue. So you can imagine that connective tissue disorders like Marfan syndrome or Ehlers-Danlos syndrome place a patient at much higher risk at developing aortic pathology. Other risk factors for developing an aneurysm or dissection include hypertension, atherosclerosis, bicuspid aortic valve, trauma, cocaine use, metabolic disorders, and pregnancy. Hypertension is a strong predisposing factor. Of patients who develop aortic dissections, 70% of them have hypertension. Classically, patients present with sudden onset, severe chest or back pain with a ripping or tearing quality. But sometimes dissections are painless. The absence of pain decreases the likelihood of a dissection, but does not rule it out. Because a dissection can affect many different arteries, vascular findings can be another clue in identifying a dissection. Many patients may present with syncope, altered mental status, paresthesias, weakness in the extremities, or asymmetric pulses or blood pressure. The vascular complications can result in strokes, aortic valve regurgitation, myocardial ischemia, cardiac tamponade, pulmonary edema, mesenteric ischemia, and/or renal failure. Sounds pretty bad. In patients who present with sudden, severe chest or back pain and are hypertensive, I would have a high index of suspicion for an aortic dissection. Add any of the previously mentioned neurovascular findings, and you very well might have a dissection in front of you. But how do you rule in a dissection? Sometimes there may be a widened mediastinum on a plain chest x-ray, which can clue you in, but it's not very sensitive nor specific. CT angiography or CTA of the chest, abdomen, and pelvis is the gold standard. This is a CT scan that uses a contrast dye to visualize the aorta. There are other imaging studies that may help with diagnosis, but the CTA is where the money is. Now that you have diagnosed a patient with an aortic dissection, what's next? Whether it's a type A or type B, the initial management includes interventions to prevent further dissection or rupture. This is achieved by promptly starting anti-impulse therapy. High heart rate and high blood pressure are the worst possible things for a dissection. I don't know if this is the best analogy, but imagine the aorta as a piñata, and each heartbeat is the stick. The harder and more frequently you hit it, the sooner it will bust open. This analogy is a little flawed because we actually hope the piñata never breaks open. What we want in this scenario is a wimpy little child whose blows are not strong enough to ever break it. And that is what anti-impulse therapy aims to do. Slow, gentle heartbeats to reduce shearing forces on the aorta. The hemodynamic goals are going to vary by physician, but a general target in most situations would be a heart rate less than 80 beats per minute and systolic blood pressure less than 120. First-line medications to achieve these goals are usually an esmolol drip and nicardipine drip. Drips are initially preferred over IV push meds because they offer tighter control. Esmolol is a beta blocker and is useful because it lowers the heart rate and may also lower the blood pressure. It is a very short-acting drug, so if you overshoot, you can lower the dose and the patient should recover fairly quickly. Nicardipine is a calcium channel blocker that doesn't affect the heart rate, but is often quite effective at controlling blood pressure. Alternative drugs for blood pressure control include clofidipine and nitroprusside. These are not first-line agents because clofidipine is still relatively expensive and nitroprusside can be challenging to titrate, and it can also cause thiocyanate toxicity. In patients whose heart rate is refractory to esmolol, I have had good success switching to a diltiazem drip. I know pharmacy may give you a hard time about combining diltiazem with nicardipine, but the benefits almost always outweigh the risks in these patients. If the patient is not immediately going to surgery, and you are an aortic center that is not transferring the dissection patient out, you can consider adding oral anti-impulse therapy to eventually wean off the drips. It is reasonable to start with some metoprolol and add additional drugs as appropriate. Occasionally, there have been patients with such resistant hypertension that they were on metoprolol, amlodipine, hydralazine, clonidine, diltiazem, doxazosin, and minoxidil. It might not seem very elegant or practical, but it was the only way to manage their heart rate and blood pressure. The one drug class we generally avoid are RAS inhibitors. Many of these patients are already predisposed to kidney injury from the dissection itself, plus the IV contrast they receive for the CTA, and an ACE inhibitor or ARB might be the straw that breaks the kidney's back. Aside from anti-impulse therapy, analgesia is also very important to add. Pain can trigger a sympathetic response and worsen hypertension and tachycardia. Untreated pain might be countering all of the esmolol and nicardipine you're giving. My personal preference is to use morphine, but use whatever is available to your practice. Starting anti-impulse therapy is your highest priority. That is what's going to prevent a medical catastrophe. But there are other things you need to do as a nurse. The next urgent thing you will need is an arterial line. Even if the doc doesn't think the patient needs one, be a pest, but do it professionally. Blood pressure control is paramount, and they will likely be on multiple meds, so an art line really is important. For dissections, most sources recommend the right radial artery. However, the location of the dissection might affect the reading. You should probably just choose the side with the strongest pulse for best accuracy. Depending on your facility, and the time of day, and the availability of the surgeons, etc., you probably will want to keep the patient NPO except meds. Even if you aren't planning on going to surgery emergently, the patient's condition can change and you might have to redline them to the OR unexpectedly. The activity order will be determined by the surgeon, but bed rest is probably the most ideal. We will be trying to achieve strict hemodynamic control, and a patient who is getting out of bed or exerting themselves can complicate our medical management. Plus, the usual risk of losing IVs or the A-line is slightly less if the patient stays in bed. Their activity level can be advanced later when the patient becomes more stable. One of the most important functions of the nurse is close patient monitoring. In the ICU, the patient should be assessed hourly, if not more frequently. Assessing pain is important not only for the patient's comfort, but a sudden worsening of pain can indicate that the patient is actively dissecting and needs a trip to the OR sooner than expected. Neurovascular assessments are also a critical component. Be sure to obtain a good baseline. Any new change in mental status, limb strength, paresthesias, or distal pulses may be an indication of worsening dissection. Since many of these patients are chronically hypertensive, it's not uncommon for our anti-impulse parameters to be a bit too low for the patient. Be on alert for clinical signs of hypoperfusion, a decrease in level of consciousness, slow capillary refill, or low urine output. These findings should be discussed with a surgeon, and consideration should be given to broaden the heart rate or blood pressure parameters. Gotta find that perfect balance. A Foley catheter is not always necessary, but have a low threshold to insert one. If the creatinine is even slightly elevated, it's probably worth having a Foley for strict urine output monitoring. Aside from the routine CBC and BMP, you may want to check coags, a lactate, and a drug screen. Abnormalities in these tests may alter your treatment plan. It's also a good idea to cross-match some blood even if the patient isn't anemic. If they need surgery emergently, it's nice to already have some blood prepared. Patients with aortic dissections make everyone uneasy. I hope I was able to better prepare you to care for these scary patients. If you found this video helpful, please hit that like button, share it with your nursing friends, and consider subscribing to my channel. Also, feel free to leave any comments or questions you may have. Thank you for watching, and I hope you will join me in my next video.